we'll make a start. I'm Heather Brown, and I've been working with Katie Bynan. We're both co-chairs of the LKN network arm for supportive care. So we've been working quite hard over the last nearly 2 years, actually, as part of the LKN to try and improve the care of older patients dealing with frailty as they develop advancing CKD or as they're already established on dialysis. So we hope that you're here to participate in a webinar discussing this issue, and really that was created in conjunction with GPs to try and address problems that you're concerned about, and where we can try and work collaboratively to help better the care for older, frailer patients. So can I have the slides up? And is everyone happy they can hear me? You're all on mute, but what we thought we would do is just, if you can put any questions in the chat as we go along, we'll try and deal with them at the end rather than as we're going through. It's just so that we can keep the flow and address the questions together at the end. Neville and Sarah and Victoria have been very heavily involved in development of these slides, so we really hope that they help provide you support, or knowing where to come for support in helping older, frailer patients who have advanced kidney disease. Next slide. So why is this so important? So some older patients do really, really well on dialysis, and they gain years of life. They improve their symptom burden, but there is uncertainty with this, and some patients who are older and frailer do less well. There are also an increasing number of older, more comorbid patients with advancing CKD in clinics, but also on RRT. And some patients may not benefit from dialysis and have a significantly better quality of life on a medical pathway without dialysis. Many patients and families, but also clinicians, don't understand the uncertainty that there is around renal replacement therapy, which is perceived as a sort of an active treatment versus, and think it must be better than having a conservative or supportive care treatment being perceived as a lack of treatment. So we want to try and help develop our renal services to better support older, frailer patients around decision making with regard to dialysis, but also as they decline in health and develop more comorbidities as they go down a dialysis pathway. So the renal supportive care pathway is to support both of those things: the patients that are in the decision-making process who may be older and frailer, but also those patients who are declining despite dialysis, having been on a renal pathway for many years. By conservative care, we mean patients with a GFR less than 15 who do not ever plan to have dialysis, also referred to as maximal conservative care. And by supportive care, we refer to patients who are having more help in terms of those that are older and frailer, whether they decide to have dialysis or not. Next slide. So this is a case study that was given to us really by GPs, so just brings a few points to the forefront of what we're trying to address with this talk. So this was a 77-year-old Bengali gentleman with stage 4 CKD related to diabetic nephropathy. Had been under the renal clinic for some time and developed advancing CKD, and his GFR was became less than 15. Past medical history of diabetes, recurrent depressive disorder with psychotic symptoms, but also vascular dementia, which was first mentioned in his notes in 2009. He was on a whole host of medications, and his clinical frailty score was calculated at 6. So quite a frail gentleman with a history of diabetes and vascular disease. He had a best interest decision to help him decide around dialysis or supportive care, and it was thought that supportive care would be the best option. But there were various issues with family not fully understanding this process and understanding the implications of not having dialysis going forward, and just needing to think about how that decision making is supported going forward. So just go on to the next slide. So the questions really from this for us were, what criteria do we use to make treatment decisions about older, frailer patients? what should GPs do about abnormal renal function tests? And often we say it's best probably not to do them, but sometimes they are done as part of the general patient overview, and they can actually be quite helpful in some circumstances, in many circumstances. What do we do about renal bone disease? What do we do about renal anemia in conjunction with you? And what do we do about advanced care planning? Generally, we like to participate in advanced care planning early with the help of the UCP, and come up with a treatment plan appropriate to the patient, which may avoid hospital admission. But often there's a bit of a disconnect between what family would like or the patient would like and what has been decided previously. And obviously decisions around patients and family may change. How can we best support that? Can we move on, please? So first of all, how do we make treatment decisions? Who chooses supportive care? Move on. So decision making around in late stage kidney disease is likely to take place in the advanced kidney care clinic, previously more widely known as the low clearance clinic, and we use principles of shared decision making where possible, provided by the help of a multidisciplinary team to ensure that patients have as much information to make an appropriate choice as possible. Patients generally move to AKCC clinics when the GFR falls to around 20, which gives us a rough equivalent to a percentage kidney function, although it's not perfect. Families, patients seem to use it as understanding of percentage kidney function. That's quite helpful to decision making and understanding where they are in the pathway. The renal pathway goes from then the advanced kidney care clinic into either transplantation, preemptive transplantation, hemodialysis or peritoneal dialysis, or deciding on a maximal conservative care pathway. And you may move between transplantation and dialysis at several stages in your life if you're a young patient going into end-stage kidney disease. Next slide. How are decisions made? So the first thing we do really in pre-dialysis clinic is involving information gathering, both from family and carers. So it's incredibly helpful to have a family member with the patient in clinic to help gather information, but also help family and patient decide what might be best for them. It's important to know what their values are, what they might want in terms of quality of life and length of life. Who are they? What's their social history like? What are their spiritual and religious beliefs, and who helps them make decisions, and can they be present? What is their functional status? That we know that this may help predict practicalities around dialysis and help us gauge their overall prognosis and as to whether sort of supportive care or dialysis may be a better option for them, and what the implications of each may be. So we often look at clinical frailty score, cognitive assessments where we're concerned about cognition, and look at their symptoms and have an estimate of which symptoms may actually be helped by dialysis to help patients understand what may get better and what may not. And what is their likely need for renal replacement therapy? So, for example, if patients are only very slowly progressing, and they may die prior to needing dialysis, then it sort of skews your decision making, and you wouldn't want to push necessarily for a decision very quickly. But it's important to be aware of the options should kidney function fall. In fact, kidney function, even when the GFR reaches about 4 or 5% or less, can still be life-sustaining. We have a number of patients on the conservative care pathway who go on for many years with a very, very low GFR with a reasonable quality of life. And it's also important to remember that at least 50% of patients on a conservative care pathway will die of other comorbidities, not end-stage kidney disease. So that may, again, affect decision-making around embarking on dialysis. Next slide. We often screen for frailty we're doing it more and more, screening for frailty in the advanced kidney care clinic, and this really helps us understand the frailty of our patients, and we're hoping more and more it will be able to gauge what patients can expect in terms of survival. And we know that there's a significant amount of frailty in older patients with CKD, and it's a really useful tool. Next slide, please. So the whole process in AKCC is really focused on a shared decision making with clinician guidance on the key issues which may affect the patient. So finding out what they know about dialysis and what it involves, and this often involves multiple visits to the clinic and discussions with pre-dialysis nurses and going through things in quite some detail. What are they hoping dialysis will achieve, and what are their goals of care? Would a referral elsewhere help their survival on dialysis? For example, would physiotherapy help improve mobility and their tolerance of dialysis and coming to and from the dialysis unit? Is dialysis right for them? Do they want to spend time having a medical treatment at this time in their life? Would they have they left home in the last month for medical care, and do they find it difficult to travel? Would they get confused in a new environment? And would they be able to get to their local dialysis unit if appropriate, or would they need to come further? Some of our older patients, because of medical stability, need to come further to an on-site hemodialysis unit for monitoring, which may be unacceptable to the patient. And discuss the evidence. And we're going to go through a little bit of evidence on the later slides on this. Will dialysis make them live longer? Will dialysis help their symptoms? Will it make them feel better and do the things that are important to them? Is dialysis practical, or is there an alternative path? Do they need referral for frailty, pain and memory clinic? Next slide. So just very, very briefly, hemodialysis. We discussed this again in quite detail with our dialysis nurses, mostly delivered in hospital or in a satellite unit, and it is quite a rigid schedule and very dependent on transport, which can make it a very, very long day. You need a physical operation to form a fistula or a procedure to have a line. Holiday is limited and there's reduced treatment-free time. It can cause disruption to hobbies, travel, and it's possible that it's life extending, but you have a shorter life expectancy than your peers, regardless of the age, but more exaggerated as you become older. Next slide. And peritoneal dialysis. So some patients may be suitable for PD, but there are a few things that would make them ineligible. For example, major abdominal surgery, but generally allows patients to maintain a quality of life at home if they're independent. So it's a small abdominal operation. It does require 5 to 7 days a week of commitment. They need space at home, and although it can be delivered with support, there needs to be a certain amount of motivation to be able to do it. Some people find that it's quite medically intrusive with complex equipment at home, and also find it difficult to accept that this is a lifelong treatment. There's greater flex with holiday and hobbies because it's portable, and often there's greater flex with fluid and fluid because it does rely on having a bit of residual function, so fluid balance and potassium seems to be less of an issue. Next slide. It is important that patients understand that dialysis only generally helps symptoms related to kidney disease. So that is those that are related to toxin buildup, such as nausea and vomiting, the feeling of breathlessness related to fluid overload, and toxins that can cause itchy skin. But there are a variety of symptoms that are very common in older patients that won't be helped. Can we move on to the next slide? So, for example, patients who may find it hard to have dialysis are those with other significant medical problems, such as mobility issues. Poor heart function and low blood pressure can be really quite difficult to tolerate hemodialysis, but actually fewer patients do quite well because it keeps them on the curve. So it's difficult to predict who will and won't do well, but can be a challenge. And people who have memory problems can find it quite a struggle to have dialysis. There are symptoms that dialysis probably won't help with, and that is mobility problems, memory problems, arthritis, incontinence, and it's important for us to consider referral to other services when other comorbidities are causing issues that may be able to be addressed to have a better experience on dialysis, especially if that's what the patient would like. Can we move on? Will dialysis make you live longer? Is supportive care not just a form of rationing? Well, I think it's important really to consider the information around this, and this is something that's quite difficult to get over to patients because it's quite complex. Whilst on average those patients that are aged 70 years or older with CKD live longer on dialysis, this is not necessarily true of older and more frail comorbid patients. But there is good observational data that suggests that if you're over 65 and spend more than 50% of your waking hours in a chair, if you're over 75 with significant vascular comorbidities, or you're over 80, on average, as a patient, you may not live longer with RRT. But no patient is average. And the level of frailty may be one of the best predictors. And we certainly know over 80-year-olds with pretty good quality of life who definitely benefit or don't do better in terms of survival with dialysis. And the Prepare for Kidney Care study is trying to seek the answers to this question by a randomised controlled trial, randomising patients similar to the groups that I've just mentioned between having dialysis or having supportive care. And that will start reporting in a couple of years' time and hopefully give us valuable information in a way that we can try and understand which patients may do better than others on dialysis and help patients make their own informed decision about whether they want to embark on dialysis or go down a supportive care pathway. Next slide, please. So just very quickly, so that I can hand over to Katie for the second bit of the talk. This is the sort of observational data that's out around how older, frailer patients do with dialysis. And if you look on the left, a group of patients that are over 75 who have dialysis do better in general. So if you're over 75 as a group, not picking out any comorbidities, you do better with dialysis. However, if you start adding in comorbidity to that, the two lines of survival are very, very similar, implying that dialysis really doesn't make much difference at all to survival. And actually, if you have a conservative care pathway, you're likely to survive just as long. Next slide. This is looking at age. This was what I alluded to in 2 slides ago around being over 80. If you're over 80, your survival curves are very, very close, whether you decide to have RRT or conservative management. But if you're 70 to 79, your survival could be expected to be longer in the RRT group. Next slide. And then this is looking at comorbidity. So where you have a WHO performance score of over 3, the comparison between dialysis and conservative care in terms of survival are very closely overlying, whereas if you've got a good performance status, you're more likely to survive for longer with dialysis rather than conservative care. Next slide. And this is looking at, again, at patients with a higher comorbidity and survival. If you have a higher comorbidity, you're less likely to do well on dialysis in terms of survival. Next slide. Undertaking dialysis may come at a cost. So the next few slides just are looking at this in terms of cognitive decline, your functional status, and additional survival days having a hospital-based treatment, and your chances of dying in a community setting or in hospital with sort of active medical treatment. Can you go on to the next slide, please? So this is cognitive function. If you look at a paper looked at executive function in patients who had never started dialysis, had started dialysis during the study and never had already started dialysis. And if you look at the executive function there, you can see that there's a stepwise decline as you start dialysis in executive function, and then a sustained decline, which you don't see if you don't have dialysis. And then on the right, there is a reduction in cerebral blood flow during dialysis in patients that are aged over 65. So you sort of can understand what's happening at that sort of level. Next slide. If we look at physical function at the start of dialysis, so if you're in a nursing home or equivalent, that may be looked after at home, but having a significant amount of care at home, you have a 1 in 6 to 7 chance of being at that same level of function in a year's time, and with 7 six of those 6 out of 7 patients having a functional decline over the year that they after they start dialysis. Can you go on to the next slide, please? And then if we look at dialysis versus maximal conservative care in terms of loss of hospital-free days versus supportive care. So if you look at the top bar, that's conservatively managed patients spending the majority of their time out of hospital. And then if you look at the lower bar, that is survival, but also the amount of time they've spent in hospital. A significant chunk of that extra survival time is spent in hospital. And this can be have a real impact on patients and what they actually want for their future when they're considering spending most of their time in hospital. But added to that, we also know that patients who are on a hemodialysis pathway are less likely to have any palliative care input towards the end of life and more likely to die in hospital rather than at home. You move on to the next slide. So we always ask patients what's important for you. It's important that you consider the key values that favour conservative care and the key values that favour dialysis. With conservative care, fewer medical interventions, no operations, less time at hospital and clinics, more ability to travel. There's a bit of a way up between quality of life and quantity of life to be discussed, and a greater chance of a community death. Whereas for dialysis, patients often always like to try the available treatment to see what it's like, possible extension of life, sociability of dialysis units. So I've mentioned how burdensome it can be going up to the hospital for dialysis 3 times a week, but some patients actually quite like it. They feel a part of the community, especially when dialysing with the same patients every week, every 3 times a week, and often feel more comfortable with more intensive and medical and nursing input. Next slide. So now I'm going to hand over to Katie for the next bit of the talk to focus on sort of what a supportive care pathway may look like and how this could be helped by you. Thanks, Katie.
Thanks, Heather. If we could go on to the next slide, please. So I think very often people end up on a dialysis pathway, sometimes because of lack of time and lack of resources to really explain to them what the alternative pathway could be. And so this is a pathway on supportive care that's been agreed across all the 7 renal units across London. And it's a conservative care pathway that is provided by all the 7 units, all of whom will have a clinic for those who choose not to have dialysis, and all of whom are now developing services for those who want to have dialysis, but also need to have supportive care provided in parallel. So as Heather's alluded to in some of the earlier slides, the first thing is really good assessment and education. And that's something we'd be really grateful if we could also share with you. If you're referring elderly, frail patients in to our renal service, perhaps with very low renal function, it's really helpful to know what is their functional status, and also perhaps what they are thinking they might get out of dialysis, because we need to be realistic with them. And that may take the form of clinical frailty scores, but we go on and we may do Montreal cognitive assessments, EQ5Ds, a proper symptom score, or even a comprehensive geriatric assessment to really understand where they are with their lives. People who have not left the house for the last 3 months, other than for hospital appointments, are going to really struggle with 3 times a week dialysis. Early management is very similar, whether you are going to take dialysis or whether you're going to follow a conservative care pathway. We're going to work very hard to try and preserve your kidney function. We're going to try and work very hard on your symptoms. And we're going to try and be enabling and protective of your kidneys. If you need additional services, such as pain control, such as a memory clinic, we're going to be trying to make sure that we signpost you and make sure you get truly holistic care. But we may also be introducing the concept that at some point it may be worth thinking about the future and doing an advanced care plan. Later management, we've focused particularly on symptoms. It's all about quality of life as their function gradually declines. And usually we find it declines in parallel between cognition, function, and kidney function. Then we're focusing very much on symptoms, moving much more towards an advanced care plan and trying to work out early on where people are still able to tell us where and how they would be like to be looked after in the later stages of their life. And then, of course, as end of life approaches, we continue with symptom control, make sure they're properly linked in with community services, make sure that their family have really good support, both before and after death, we hope. And make sure that if necessary, we know where they would like to be at the last stage of their life, and we do our very best to achieve that. Next slide, please. So this is a sort of simpler visual version of that pathway that we wrote for a recent article in a book. And I think it can be summarized to say that it is genuinely an enabling pathway. It is a pathway that will give you greater freedom. If I can just quote one of my patients who said to me when I explained to him about hemodialysis, "Are you going to tell me that you can make me live twice as long with dialysis? Because it seems to me that you're going to waste half my life with dialysis once I've spent 3 days a week with you." And I think that's a very nice, simple way of thinking about it. Whilst it may not quite be 50% of your life, it is a very significant treatment burden. So we like to think this is the freeing up pathway. We want to make sure that people have true information, and ultimately it is their decision. This is not rationing. If they want to do dialysis, and it is technically possible, we have slots and we will always support them. We want to make sure that we optimize their function. So that's not just about getting them out of pain. It's not just about stopping them having falls, but it's about things like getting abroad if they want to see that new grandchild, to know that they can go back to India for 3 months, to carry on going on that cruise. It's about planning for the treatment escalation plans and the preferred place of care. And it's also about looking after the wider needs of the family. So often it is the family who perhaps have missed out on those early discussions, who do not understand the pathway and probably perhaps do not understand the very marginal or possibly no benefit of dialysis for their relative. Could we have the next slide, please? So this is just some data from our patch in Southeast London, and this is just about doing clinical frailty scores. And the left-hand histogram that you can see is really to show you that in our advanced kidney care clinic, that's the patients who come with less than 20% of kidney function, and it's traditionally where we plan for their next stage of care. And what you can see is that we scored everybody, or we attempted to score everyone who was 60 or older. And I think it's worth saying that patients who have kidney disease in the later stages of kidney disease are generally thought to be physiologically 10 years older than their chronological age. So that's another key point to remember. And if you look at the patients who are over 60 on IKCC, of the ones who were scored, over 2/3 of them were either intermediately frail with a score of 4 to 5 or severely frail with a score of 6 to 9. So this is a frail population who are running into dialysis in our older patients. And people often worry that our supportive care patients must contain lots of people who are actually young and fit and relatively well for their age. But actually, I hope that we work really hard to make sure that we guide the right people towards supportive care and the right people towards dialysis. So if you look at the pie chart on the right and you look at everyone that's between about 12 o'clock on a clock face to about 8 o'clock on a clock face, all of those colours are the colours of severe frailty. The scale is very small, but they all have a frailty score of 5 upwards. So what you can see is the vast majority of the people who choose supportive care are very frail. The ones who are in the part of the clock between 8 o'clock and noon, who have slightly less bad frailty scores, are often very well-educated patients who are in their 80s or 90s, who once they've heard about dialysis make a very rational decision that it is not for them. They do not want that level of complexity at that time of their life, and they want to have quality of life for whatever time they have left. Could we have the next slide, please? So you and they often ask us, well, how can our kidneys be protected during this phase when we're trying to do everything we can to make them last as long as possible? And it's really the obvious thing. So we avoid the kidney toxins, don't give them non-steroidals by accident, avoid trimethoprim, which so often causes problems when it's used to treat a urinary tract infection because it prevents tubular secretion of creatinine and makes their kidney function look artificially high. And please feel free to use the Renal Drug Handbook. Your community pharmacist should be able to help you get a link to that to dose adjust any drugs that you want to use or check whether they're safe in different degrees of renal function. Blood pressure. We're not going for perfect targets, as you well know, in people who are older. And in fact, 150/90 may be very tight for an older person who's more in danger of falling. So we're going for a very different set of targets. Just to warn you, people who are on insulin will often retain the action of the insulin for longer as their kidney function retains, because their kidneys are one of the organs that causes the insulin to degrade, and therefore it will last longer in people who have kidney problems. So the greater danger is actually hypoglycemia, and contrary to what they expect, they may find that they can cut their insulin repeatedly as their kidney function declines. Treat any infections promptly, particularly UTIs, and obviously be aware of radiological contrast. Although well managed, they can generally have the X-ray and CT scans that they need. Could we have the next slide, please? And the next one, please. So often we're talking about symptoms, and so often the symptoms they're actually describing to us are not actually related to kidney disease. So it's really important to have a holistic clinic, and both Heather and I are lucky enough to be part of a pilot in South East London at the moment, where we're going to be bringing in some additional therapists and a geriatrician to our late stage kidney disease clinic to try and help us to deliver some of these things. So they may actually require signposting to a falls clinic, a memory clinic, to counselling, to comprehensive geriatric assessment. I had an 89-year-old lady in my clinic on Tuesday, and before she left, she'd seen our physiotherapist for falls, who'd then rung an occupational therapist, and she'd also seen the dietitian because she was malnourished. Those were the things she needed far more than she needed dialysis. Please, could we go on to the next slide? So targets, what's really helpful? You often ask us about these questions. So it's probably only targets that are relevant to short-term prognosis. Blood pressure control is not about strokes and heart attacks that are going to occur in 10 years, because that's not the timescale we're thinking about. We can also think about how we can deprescribe. I think it's very difficult to know whether a statin really has any value in this group. And anything else that's long-term, think really hard. What is it that we really want them to take? And what is it that's actually helping them? Should we be treating phosphate? Well, I think we should be treating it if it makes them itch that they're very hypophosphatemic. But sometimes phosphate is simply a sign of a good diet, which may be very good for them. Hemoglobin, I think if it helps their breathlessness to try and raise their hemoglobin, but provided it's above 9, I wouldn't necessarily try and get it to any particular target. And if they're asymptomatic at 8, because they're not moving around very much, then actually they may prefer not to have injections. PTHs, it's a cause of great distress for everybody. Don't treat it just because it's above the normal range. You don't need to. The easily correctable, think about trying to bring their phosphate down if we think that's driving it. Replace vitamin D if that's easy, but very often it's not causing a problem. And then realistic expectations. If we can make their symptoms 30% better, just as the oncologist would consider that as a success, we probably need to work to that. We also need to be honest with patients. We don't always have the perfect solution. So sometimes balancing fluid overload versus uremia can be quite challenging, and we have to try different doses of frusemide to find the one that gives the patient the most acceptable form of symptomatic relief. Could we go on to the next slide, please? So I'm just going to show these, but there's a lot of information on them. And as somebody asked earlier, these are all going onto the LKN website, so there'll be plenty of time for you to see them later. These are slides kindly written by the team at the London, led by my colleague, Will White. And what Will's done is to put together some incredibly useful practice points for the older, frailer population, particularly those who are going along the supportive care pathway. I think it's important to remember that sometimes even these patients have acute declines in their kidney function. So if you see a patient on this kind of pathway and they've suddenly gone from a kidney percentage of, say, 18 to 6, then it is worth checking for obstruction. It is worth doing a myeloma screen. It is worth making sure they don't have a urinary tract infection. But generally, we do fewer investigations on this patients, not more. And as I say, the relief, it's all about symptomatic relief. And in the right bottom corner, Will's given you some very helpful guidance on EPO management in case you end up helping with that. Could we have the next slide, please? Once again, just some top management tips. Just looking at things like you can often make people more comfortable in terms of dangerous potassiums or dangerous phosphates with a bit of dietary advice. But I also think you have to remember, as one of my patients said to me, you may care what my potassium and phosphate are, but I don't care. And I understand the implications of that. So it's important to be sure that they really want to limit their diets, or maybe actually their quality of life is more important. We talked a little bit about vitamin D and hypoglycemia already, and the importance of deprescribing. And just to say, be careful with ACE inhibitors and ARBs, because these patients are a little bit more prone to having hyperkalemia. And also thinking about beta blockers, which again can accumulate in end-stage kidney disease and therefore can be a bit more potent in causing very slow heart rates. Could we go on to the next slide, please? And the next one, please. So one of the things that Sarah and Neville asked us in their case study was to think about what happens when you do get to those late stages of kidney disease, and suddenly the family feel in a great panic and they suddenly start saying, well, what about dialysis? So, and I think that's very natural. Many of us have dealt with our elderly relatives and had to think about what was right at each stage, and it's a very difficult phase. So I think we can do certain things, hopefully, to reassure them. So first of all, is the cause of the deterioration actually their kidney decline? Or is it really that they're becoming older and what they really need is to see a good geriatrician? Could they solve many of the problems? It's important to remember that even when you get to 4 or 5%, you probably have another 6 months to live, and certainly at 8%, if you were to die, it wouldn't be because of your kidney problems. It would probably be because of other problems such as vascular disease. And that's what we see, 50% of patients die of other causes. Of course, if the patient is genuinely changing their mind, we are listening, and patients are perfectly entitled to change their mind. But actually, is it the family who are changing their mind because they need more reassurance? Is that about excellent and realistic symptom management? Is it about practical help, getting an OT or a physio in, the continence team? Is it about memory? It's also, I think, really important to reassure the family that their loved one isn't missing out on treatment, which would make an enormous difference. Two of the things I say a lot in clinics is this is not rationing and you can have dialysis if you want it. And secondly, I have to be realistic with you and say this will not change the trajectory of your relative, because we all fight for what we believe is right for our relatives. Is it actually that the family need the counsellors? Sometimes they haven't been in on the early discussions and they have not understood the marginal benefit of dialysis. And then it's about community support for them. Could we go on to the next slide, please? And the next one. So the next 3 slides that I'm going to show are really an acknowledgement that we do have to have difficult conversations in this area. So Anna Winterbottom, who is a psychologist who works very heavily with the Leeds Renal Group, has drawn up a book recently called Difficult Conversations, and we'll show you in the resources section at the end how you can find it. And Anna acknowledges that there are lots of different and very strong emotions that come through when you try and have these conversations. So she has written a guide to some of the phraseology and the ways that you might think about it. So the first thing she deals with is anxiety, and pointing out that very often when we have the conversation, we can reassure them that right at the moment they are well. We are making plans for the future, but that their kidney function is stable at the moment. And that's really important because many people imagine when they come to clinic that they need to have dialysis immediately or pass away. Next slide, please. And a second issue is that she deals particularly with sadness and fear, and letting people express that and giving them time to express it. And again, she's come up with a lot of different phrases that you can use, and you will need to read this and choose your own phrases that you find really helpful if you find such resources helpful. And then thirdly, if we could just go to the next slide, please. Anna reminds us, I think, in this slide that very often patients feel very angry, and sometimes they can take that out on the healthcare professionals that care for them because there's nowhere else to take it. But of course, they're not angry with us. They're angry with their disease and with what's happening to them. And enabling them to acknowledge that and giving them space can be really helpful. acknowledging their frustration and trying to show them that you're listening and you hear their symptom burden, or you hear their sadness that they will not see their grandchild get married in 5 years' time or whatever, is really important. Could we go on to the next slide, please? So very quickly to finish, we're just going to talk a little bit about why we need supportive care principles in our parallel dialysis and transplant population. And if we can go on to the next slide. If we go on, please. So it's in a nutshell here, and this is particularly why we need it in our dialysis populations, because our dialysis population is old and frail, and because it is physiologically 10 years older than our chronological ages. If you go on, please. Other slide. This, I'm afraid, is realistic prognostic data. So on the left-hand side, you can see the chances for different ages that you will still be alive a year after you start dialysis. But more recent data that's on the right-hand side shows you that if you are in the best 25% in the blue column, the middle 50% in the red column, or the green, sadly, worst 25%, then those are the average life expectancies that you have. And what you can see is that if you are in the worst 25%, and they're very often the people who we are helping with the conservative care pathway, your survival at all of these ages is often less than a year. Could we go on to the next slide, please? So, and again, this is sort of similar to the data that Heather has already showed. It is all about comorbidity. Could we carry on, please? Next slide. So what does it look like providing help to our dialysis patients, and how can we do this together, the community and us? So I think the first thing is that we have a responsibility to have honest conversations before they start. And we hope that you can help us give realistic expectations before they start about reduced prognosis, about the limitations, as well as the good things about dialysis. We need to focus on optimum quality of life. Maybe it doesn't matter what their toxin clearance is, or their blood pressure, or their phosphate. I say that because these are the things that renal doctors, kidney doctors are obsessed with when they think about kidney patients. But actually, maybe all that matters is their symptoms, whether they're getting out to do things with their friends or managing to have a quality of life. It's important to be honest about the shorter prognosis so that they can do the things they want to do. And it's important to make sure their family are aware. And we also need to reduce all that polypharmacy. We do need to give patients permission to stop. I never encourage patients to stop dialysis, but some patients are dialyzing for us and not for them. And that's really important. They understand they have that option. But there's also opportunities for altered dialysis sessions. Again, we may want them to do 3 times a week for 4.5 hours. They may want to do twice a week for 3 hours. We do have a responsibility to listen to what they need, as long as they understand the consequences. And together we can build for the future by doing lots of advanced care planning. And on the right-hand side, you can see that we work with our community teams. We want to work with you and have fantastic relationships with our GPs who help us with this. And we work with our local hospices, as in St. Christopher's at the bottom. Could we go on to the next slide, please? Final couple of slides. This is really just to say that if you look at the grey and yellow bars in this histogram, which is taken from lots of our dialysis units that Heather and I look after, there are lots of frail people. These are the people who are frail in our unit, and you can see there are plenty of them. And in some units, most people are frail. Could we go on to the next slide, please? So about 15 to 20% of people in the UK will pass away because they stop dialysis. Sometimes that's initiated by the clinician because it is simply no longer possible to continue dialysis if they're very sick in hospital with a low blood pressure. But not unusually, it's initiated by the patient. And there may be a very good reason. They've made it to their 50th wedding anniversary. Their partner has sadly died. They are aware that they are no longer able to enjoy life after a stroke. Or they're in a residential care home. They're no longer able to recognise their family. Perhaps they told their family that before they got to that point so that they could help us and tell us. Occasionally, they're no longer able to drive, don't want to have another vascular access procedure to make a fistula, or don't want to go on a much longer journey to a more medically supported unit at base, and therefore decide that their journey with dialysis has come to an end. Could we go to the next slide, please? We never stop dialysis as a quick process. So we will always have worked with them to try and create an advanced care plan and looked at alternatives, like trying to treat any depression, changing their dialysis plan, improving their symptoms. But ultimately, if they want to stop dialysis, then it is our job, of course, to support and to get palliative care in place who can support them and to try and achieve their preferred place of care at end of life. This is the Guy's protocol of how they do that. And it's just to reassure you, it's a very carefully thought through. We always allow them a cooling off period before they make the final decision, and we support them throughout. Could you go on to the next slide, please? So people on the final slide sometimes ask us in primary care, how can we help you to deliver what you need to deliver? And I think there are some very simple things to do. One is expectation setting. Some patients will do brilliantly on dialysis. One of my patients at the Bromley dialysis unit is celebrating their 90th birthday today. But that's not the journey that everyone is lucky enough to enjoy. So it's about realistic. If they're very frail, it's about being honest about the fact that dialysis may achieve relatively little and that there may be equipoise for many patients. It's making sure that we really understand how much of their symptoms are related to dialysis and how much are simply related to other aspects of frailty and could be treated much better by other teams. I think it's about us joining together to make good advanced care plans, and we're very open to discussions. So please call us because we do have local supportive care services to try and support you. Could we go on to the last couple of slides? So we've put together some resources for you, and I'll just run through these because you can find them on the LKN website. We have a staff education package. I'm just going to show you a couple of slides about that. We have some patient information booklets which are going to come on there fairly soon. They're just with graphics, all about how patients, to give patients information about making that choice, if they want to, how they might stay well without dialysis, planning ahead, etc. Could you go on to the next slide, please? We've got some national resources and they're all there. Those are our big websites. They're all fantastic. Please do go and have a look at them. And then the next one, please. This is Anna's booklet about difficult conversations, and we've given you a website. And then the next one, please. And this is an e-learning module which is about to go live. It'll go live later this autumn, and it's aimed at professionals. We realised that a lot of our staff didn't feel confident to talk about this area when we did a survey a few years ago. So Sarah Mackey, one of our amazing nurses, has generated for us 2 big education packages, one about supportive care and one about advanced care planning, which have been through a production process and piloting and are now being rolled out to all our staff. They're in bite-sized pieces of education. And if we could go on to the next slide. They just answer some of these questions, which you can have a look at after the talk, in very bite-sized pieces, so that if any of the staff in primary care would like to have a look at this and just feel a bit more confident in their knowledge, they're a fantastic resource. And then final slide, please. And here's the website for you in case you want to go back to it. And as we say, going live in November. So give us a month and then hopefully they'll be live on there. Sarah's very happy to take any questions. And then if we could go just on again. If we go one more. I just want to acknowledge an awful lot of people work on this area. We're incredibly grateful to Neville, Sarah and Victoria who helped us to co-produce this, but it wouldn't have happened without all the fantastic supportive care teams around London. And I'd also like to acknowledge Nick and Marisa at LKN for all their support of our work stream. And I think we have a question slide. Thank you.
So, Katie, we've got some questions in the chat, so I'll read them out and you can work your way through them. So the first one is, why is diabetes type 2 so high among South Asian males? Should HbA1c treatment start earlier than 48? And why do they all get CKD, CAD and diabetes? Does salt content and high carb diet with no exercise play a part? That's your first question.
I'm afraid I'm going to field that one and say that's a PhD thesis somewhere. It's a fantastic question, but it's probably beyond the scope of this talk. So I'm sorry, and I know there's one coming up on SGLT2 inhibitors, but I can give you a useful resource for that. The best place to go and have a look for a really good guide about SGLT2 inhibitors, go onto the United Kingdom Kidney Association website, go to their clinical practice guidelines, and they have a fantastic interactive guideline about the use of SGLT2 inhibitors with a really nice summary page. So can I direct you there, because it's much better than I will ever be at describing that.
And I'm going to put another plug in for the LKN guidance on managing CKD early as well, and the guidelines for that are in the chat already. And then the next question is around the role of diet and exercise. And yeah, what is the role of diet and exercise in preserving kidney function?
So I'll take perhaps that one and then hand over to Heather for a few questions. So I think there is very clear evidence that there may be some benefit in the early stages, that there is some evidence that you can slow down with some good exercise. And of course, often improves weight and improves endovascular function and so on. There's a lovely tool called Kidney Beam, and you can just Google that. Kidney Beam was generated by a group of physiotherapists. And it's an online tool, so you don't even have to necessarily come out of your home. It's a digital tool. You can go in via Zoom, and you can either join a class that is live to do some physiotherapy, and you can do both standing or you can do seated exercise. So it's suitable for people who are really quite frail. Or alternatively, you can watch a playback video if you don't want to join in the class live. It's an amazing resource that has loads of resources for people with kidney disease who want to dial in digitally.
I'm delighted to say I've put the link for that into the chat already as well. We don't have any other written questions at the moment, but if anybody else has got a question, if you raise your hand, I can unmute you, or you can put it into the chat if you prefer.
Shall we, while people think, just see if we've got the LKN, some of the LKN supportive care staff here, and see if we could, we'd love you to meet some of the people around the region who are leading the work. And I'm going to ask Heather to lead on introductions. Do you mind, Heather?
Yeah, that's absolutely fine. So I'm Heather Brown. I work at GSTT. I introduced myself at the beginning. I know a lot of people have joined since then. And what we're hoping to do with the webinar is put some appropriate contacts for your local units on there, so you know who to contact about any difficulties locally. So I think I saw Dave Evans come on from St Heliers. Are you able to unmute yourself and show us your picture? So if anyone's in the Heliers.
Hello, I'm David Evans, one of the renal consultants from St Heliers.
So if there's anyone in that region, David is your man locally.
I also work in the Frimley area, so if you're out that way, the sort of Frimley, Wetson Park areas, I could also cover sort of close to that bit too.
Thank you, Dave. Have we got Lina from Hammersmith there? I can't see.
I don't think we do. We've got Will from Barts.
Oh, Will.
Yep. And we've got Tatiana from St George's. We've got Jaron from Barts. We've got Lizzie from Imperial.
So from the Royal London, we've got Will White, and Jaron was there, I think, with you as well, isn't she, Will? So Jaron, I don't know whether you want to come and introduce yourself. Will, over to you.
Yeah, I can introduce myself. So I'm Will White. I'm a consultant nephrologist at the Royal London Hospital, and also an honorary consultant nephrologist at the Homerton, and with Jaron, and I think Dawn Yoakum is on here, and Ruby Tyab is on here as well. So Dawn is our dietitian, and Ruby is another of the supportive care CNSs. We cover supportive care for Barts Health and City and Hackney as well. And I think Jaron is the lead CNS.
Great, thank you, Will. And then we've got Tatiana, who is very is at St George's. I think Sima's not on today, the consultant lead, but Tatiana is the nurse, the main nurse in control of the services at George's at the moment. So Tatiana, do you want to introduce yourself?
Yeah, thank you. So yeah, my name is Tatiana. I work here at St George's as the nurse specialist in supportive care. We're also trying to, so our patch currently covers just St George's, but we are also trying to look into now expanding into Kingston as well, if any of you work out there as well. It's very much a nurse-led service here at St George's, so everything still goes through our advanced kidney care team, who we work very closely with, but it is, once they reach supportive care, it's very much nurse-led.
And then I don't think we've got anyone on from the Royal Free, but do put your butt in if I've said that wrong. But Collie Crawford is the main representative from the Royal Free, who's been very heavily involved in the LKN. And again, we'll just need to make sure that all of these contacts for each unit, in terms of the consultants and the specialist nurses, are on the presentation appropriately for your locality. And then from the Hammersmith Hospital, Lina is the main nurse consultant specialist in who's responsible for supportive care at the Hammersmith, and we'll make sure you've got all the information and contact.
We've got Lizzie Dolby.
Oh, is Lizzie here?
Imperial. Yep, she is.
Lizzie.
Hi, so I'm Lizzie. I'm the AKC lead. We also have Lane, who is our frailty nurse. I don't think she's on the call. So there's myself, Lane, Lena, and I think that might be it, actually.
Thank you. Thanks. So, as I say, we'll make sure that the contacts are available, so you know who to contact in your area, and also very interested going forward about how we can help in any other ways to help disseminate knowledge. Obviously, the webinar will be there now, but if you do have any other questions about or comments on how we can make the pathway for these patients better, then do get in touch. Very keen to hear from you.
I think we'd also just like to say a big thank you to primary care for all your hard work with our patients and the patients that we share, because I know that very often you're dealing with the sharp end, and we're very grateful. We're always keen to work with you and to make the service better.
Looks like we've got one suggestion for some work to do next from Kavita.
Yeah, I think that's a very good comment. So that is about acceptable targets for things like hemoglobin, creatinine. I think that would be very helpful, wouldn't it? Because, you know, we all have dialysis targets that are very well described, but actually these change, don't they, for these older, frailer patients, where you're trying to balance so many things and maintain a quality of life. So if there's no more questions or comments, I think we'll bring it to a close, if that's okay. But thank you all for coming.